all, and welcome to our IVF webinar. Once again, it's great to be back with all of you, and also it's great to be back with Dr. Esther Marbán. You can see her right here. I'm your host, Caroline, and Dr. Esther, how are you feeling tonight? Hope you are very, very excited to have you to be here with us.
Thank you, Carla. I'm really happy to be here with you tonight.
I am very, very excited as well to have you with this kind of topic because actually this is our first topic on this particular fertility hormones. Of course, it has been mentioned before,
Mhm.
but we've never had like separate topic IVF webinar. So thank you so much for bringing this to us as well. And as always, just let me tell you that my Avivences, as you know, is a part of European Fertility Society. We are here every single day to simply support you, to us, to answer your questions, to help you out as much as we can, and we will continue to do so. And today we have a very, very special event actually as well for us, simply because it's our 300th webinar. So as you can imagine, lots of work has been done, and we are definitely very, very proud to be able to do that. And also I wanted to thank you for joining us, because of course without you, our patients, there wouldn't be a point to do the webinars, of course. So thanks a lot for joining us over and over again. It's always great to have such an amazing audience. Thank you so much indeed. And as you know, Dr. Esther Marbán, or if you don't know yet, because Dr. Esther has been with us before, she had a few webinars with us already. So Dr. Esther is the gynecologist and fertility specialist at Clinica Tambre. So we are very, very happy to have you back. Okay. And I guess that will be it from me. And Dr. Esther, ready to go ahead with the presentation?
Uh-huh.
Perfect.
Hello, everyone. As Karen has said, I'm Dr. Esther Marbán. I have been working at Clinica Tambre for 11 years now. So I'm really happy to be with you today. And let's start with the presentation. Okay, so today's topic, as you may know, are the fertility hormones. So we will be talk about the FSH, LH, estradiol, and AMH. So, first of all, let's talk a little bit about the importance of the hormonal assessment. So, they are essential for the ovarian function knowledge at the fertility consultations and to do a proper diagnosis in each patient. Of course, they are also important for the ovarian reserve assessment and to predict the patient's response to medication, select the treatment protocol and medication dose. Let's start talking a little bit about the FSH. The FSH is the follicle stimulating hormone. It's produced in the anterior hypophysis in response to pulsatile gonadotropin releasing hormone stimulation. The combined action of FSH and LH stimulates the ovarian follicle growth. Normally tested with a simple blood sample on day 2 to 4 of period. The normal levels are the following. When the FSH is below 10 milliunits per milliliter, it's considered normal. Between 10 and 20, it suggests poor ovarian response to ovarian stimulation. And when it's over 20 milliunits per milliliter, it suggests low ovarian reserve and poor reproductive outcomes. In general, high FSH level may be found due to age, in menopause, and primary ovarian insufficiency. In contrast, low FSH levels may be found in combination with low LH levels, may indicate a problem in the hypophysis. In that picture, you may see what we call the negative feedback loop, in the hormonal secretion. So in the brain, the hypothalamus produces the gonadotropin releasing hormone, which is transported to the anterior hypophysis or pituitary gland, where both FSH and LH are produced. Both LH and FSH act in the ovaries to secrete estradiol and progesterone. When the hypothalamus and hypophysis notice an increase in both FSH and LH, the producement of FSH may decrease. So the same happens, and well, I would say that the opposite happens with low levels of FSH and of estrogens and progesterone. When that low levels of estrogens and progesterone are found, they would have the opposite effect. So in the end, we will find a high FSH and LH level. So that's what happens, for example, on menopause. On menopause, there are no estrogens circulated in the blood. That's the reason why they have that negative feedback, and actually they don't have that negative feedback, and in the end, we may see that FSH levels quite high. So that FSH, is traditionally used to evaluate the ovarian reserve, which means how many eggs or the number of eggs remaining in the ovaries. But that FSH is not the best ovarian reserve maker. It varies throughout the menstrual cycle and also from cycle to cycle, which is something that we should consider. Apart from that, there are big differences in the normality levels, as we have previously seen. So we need to add other hormonal tests to perform a proper diagnosis and to know the patient's prognosis to stimulation in IVF. It cannot predict the success of an IVF treatment either. And what about the LH? So the LH is also produced in the anterior hypophysis or pituitary gland in response to pulsatile gonadotropin releasing hormone stimulation. The combined action of FSH and LH stimulates the ovarian follicle growth, but the main important role of the LH is that it triggers ovulation. So the ovulation may happen 24 to 36 hours after the LH surge. It releases impulses, so a single blood or urine sample may not detect the LH rise, which is something that we should consider also. In reproduction, it's commonly tested on day 2 to 4 of period. So we know that in some cases of polycystic ovarian syndrome, primary ovarian failure or menopause, they are related to high LH levels, as we mentioned before. But the opposite happens in some cases of amenorrhea, where we may find low LH levels. Let's talk a little bit about the estradiol. It's a type of estrogen. It's produced in the ovarian follicles as they grow. The normal level on days 2 to 4 of period are between 25 to 60 picograms per milliliter, and normally it improves the predictive information of FSH. Traditionally, high estradiol levels in early follicular phase, days 2 to 4 of period, are related to a worse ovarian response to stimulation, which means higher cancellation chances and lower pregnancy rate. But a systematic review concluded its lack of clinical usefulness in predicting low response. That's the reason why we normally test the estradiol, but we know that it's not the best marker to consider if we are talking about testing the ovarian reserve. So the role of the basal estradiol determination in the prediction of ovarian reserve is currently debatable, but it may help in identifying patients with low ovarian reserve and falsely low FSH levels due to high estradiol levels, as we mentioned before, because of the feedback and the loop that we have seen in the previous picture. High estradiol levels could, in the end, inhibit the FSH secretion, and we could think that due to the FSH, the low FSH, that the ovarian reserve could be fine, and actually it couldn't be in the end. And let's talk about the AMH. The AMH is the most important way how we assess our patients on the ovarian reserve. The AMH is a glycoprotein growth factor produced by the granulosa cells of the antral and preantral follicles in the ovary. In that small picture, you may see the antral and preantral follicles are the smaller follicles that we may have in the ovaries. They are normally measuring between 2 to 8 millimeters, and sometimes they can be seen with an ultrasound also. So apart from doing the image, which is not the topic today, we normally do another test, which is a vaginal scan, to test and to count the number of follicles, antral follicles that we may see in the ovaries. With both tests is a really good way to know about a little bit more about the ovarian reserve of the patient. So as we were mentioning before, that AMH is produced like in the external cells of that antral and preantral follicles in the ovary. So the AMH is known to be a regulator of the recruitment, preventing depletion of all the primordial follicular pool at once. It does not vary during the menstrual cycle, which is something really important to consider, as we may measure that AMH at any point of the cycle without any particular changes. So as we were mentioning, it can be drawn on at any day of the cycle. The normal levels can be, well, in that part, I want to stop a little bit because as you can see in the slide, the normal range may change depending on the woman's age. This is very important to consider. So you can see that, for example, if we are talking about an AMH below 1 nanogram per milliliter, it may suggest low ovarian reserve. But it's not the same finding, for example, an AMH below 1 in a patient which is around 30 years old than in a patient which is around 45 years old. So if the patient is 45 years old, of course, the ovarian reserve is reduced due to age, which is something not so common to find in a patient in around 30 years old. So it's important to know the normality levels, but it's also important to consider the age and other factors to do a good assessment on that patient. So if the AMH is around between 1 to 3 nanograms per milliliter, it's considered like a normal ovarian reserve. And when it's over 3 nanograms per milliliter, it's considered high ovarian reserve. So in that picture, in this slide, you may see that important picture, which means how age could affect the ovarian reserve, which is something that I'm sure that is a topic that we have been mentioned before in the previous webinars. So as the quantity of follicles in the ovary reduces, the AMH level also drops. That's the reason, as we were mentioning before, that as the AMH is produced in that antral and preantral follicles, if that follicles start decreasing, the AMH will decrease also. So you can see with a black line how the ovarian reserve decreases due to age. The opposite happens with the FSH, as we mentioned before. If the FSH increases, it could be a marker of low ovarian reserve also. And the opposite happens with the antral follicle count and the AMH. They both decreases as the woman gets older, which is the normal situation we find in the consultation. So if we have a patient in their 40s approximately, it's quite common to have low AMH levels and low antral follicle count. So the opposite happens with young patients that normally have like a good ovarian reserve, but not in all the cases, of course. So the AMH is a predictor of ovarian response to stimulation in IVF. So it means that it can give us a good approximation of the numbers of eggs that we may retrieve, but that AMH is not related to egg quality. So we have a better marker of the quality, which is the age. So normally patients that are older may have a poor egg quality, normally, not always, but sometimes it's related. But the opposite happens with young patients. The AMH also helps in predicting risk of ovarian hyperstimulation syndrome in women with high AMH levels, which is something important to consider also. So in that situation, we should use low stimulation doses, trying not to push the ovaries produce so many follicles and so many eggs in that patient, because we know that the risk is there. So the AMH also help us in trying to decide the dose we should use in each patient, especially in young patients with high ovarian reserve. We should use low doses of stimulation. As we mentioned before, also, low AMH levels are associated with high cancellation rate due to low ovarian response to the stimulation. And that AMH is not a predictor of whether a woman will get pregnant or not, and can't predict how quick the ovarian result will decline, which is something that we normally find in the consultation. Many patients, when they have the AMH level, they sometimes ask us if we could predict how fast and how quick that ovarian result will decline, and it's impossible to know. So each patient is different, and the speed of that follicular decrease, it's impossible to know, because each patient has like their own take on that. So what are the conclusions of that? So the main ideas to take home are that the hormonal testing is absolutely essential for a correct ovarian function knowledge in reproduction. It is a test that should be done to any patients in order to provide a good assessment on them. LH and estradiol do not have an important role in ovarian reserve assessment. FSH on days 2 to 4 of menstrual cycle is an important ovarian reserve marker, especially in combination with AMH, which nowadays is the most efficient and effective marker. So we normally do the AMH in our consultation, as well as the antral follicle count. So the idea is having the best assessment in each patient, to have like a proper diagnosis, and of course to decide the dose of stimulation and the prognosis of that patient into the stimulation. And thank you very much. So I will wait for your questions. I'm sure that you will having some of them.
Yes, you are very right. Dr. Thank you so much. As always, you've been thorough with explaining all the details, of course. And yes, there are some questions ready, but of course, if you ask your questions, you know what to do. Just go ahead, type those in, and Dr. Esther will help you. I have no doubt here. So let's have a look at the very first question that we got from Elle. Does high FSH always mean menopause?
No, not always. So when we are talking about a patient on menopause, approximately the FSH level could be around 50 or even more. So if that patient has that kind of FSH, we could think that maybe the menopause is there. But having, for example, FSH around, let's say, 25, it doesn't mean that there is a menopause in that patient. It does mean that the ovarian reserve is quite low. Of course, it depends on the moment when that FSH is tested, because if you test it, for example, at the end of the cycle, of course, the meaning would be completely different. But if we are talking about a quite high FSH, around 50 or even more, we would think that that patient could be on menopause, but not all the FSH levels means that the patient is on menopause, of course.
All right. Thank you so much for the very first question. And of course, for your help with that. And next question from Joanne. Okay, this is a question that I'm sure you received very, very often.
Yeah.
Okay. Can I increase my ovarian reserve naturally?
I'm afraid you can't, Joanne. So all women are born with around 2 million follicles and eggs in our ovaries. And as we get older, that follicular that follicles are will start to decrease. So by the moment, it's not known any way to increase the ovarian reserve. So it's known that, of course, if you have a healthy way of life, trying to avoid some kind of oxidants, in the end, it will affect in a positive way to the ovaries, but there is no way to increase the number of follicles or eggs in this moment. So there are some research of trying to do some kind of procedures in the ovaries in really young women that have really low ovarian reserve. But by the moment, it's nothing that we can't talk about to the normal population, because there are just some examination and some research on that, but not to apply in the clinic in our clinical and daily life. So I'm afraid that we can't increase the ovarian reserve naturally in this moment. There is no way to doing that, at least by the moment.
Okay, thank you so much indeed. And actually, as we are on that topic, there are like another question. Okay, so how can I boost my fertility hormones?
Actually, we don't need them to be boosted. I mean, so we need like a normal ovarian reserve, and that apart from that, that the ovaries work properly to the stimulation, which is not so easy to read. So in the end, if we have a patient with a normal ovarian reserve or even with a low ovarian reserve, trying to push the ovary work better in the way that giving the medication to try to make the follicles grow may help in the achievement of having a good number of eggs in the end of the stimulation. So there is no way to boost your hormones, because in the end we don't want them to be boosted. I mean, so we know the axis and we know how it works. So we need the ovaries work as much as possible to stimulate during the stimulation. So it's just a problem of finding the good way to stimulate the ovaries to try to have the best option in that patient and retrieve a good number of eggs in the end.
All right. Again, thank you so much. Okay, and I need to go ahead with the question here. Could ubiquinol improve egg quality?
Actually, there are many different molecules that are supposed to increase the egg quality. But if we are talking like in serious research and so on, there are not so many papers stating what kind of medication or chemicals may help us in improving the egg quality. So Ubiquinol and some others are supposed to be related, but in the end there are no important data of like good results with that. In the end, we know that there are many vitamins and some other coenzyme Q10 and so on that are supposed to increase that egg quality, but in the end, the results that we see in the consultation are not different. So many patients take like vitamins and some other antioxidants trying to increase and to improve the egg quality, but in the end, the results are not so good.
All right. Thank you so much. Well, actually, there is, as you could imagine, there will be questions on that. Can we improve our quality supplements such as smaller? You said a little bit on that, of course. So it only takes one egg at the end.
Exactly. So, of course, many patients take that kind of, melatonin and so on, because they are quite powerful antioxidants. Because what is known is that sometimes when we are talking about low iron reserve, especially in women and in young women, in some occasions, it's thought that maybe the problem is that there is a quite oxidant environment in the ovaries, and it may affect the egg quantity and egg quality. So, because of that, sometimes using that kind of antioxidants may help us in the way of trying to improve the egg quality. What is seen in the consultation is that many patients take that supplements in their daily life, but in the end, the results don't change a lot. So, of course, they are not going to do any bad effect to the egg quality. What is what we should consider if they are helping us or not. Maybe I think that the egg quality it's really really difficult to be changed, and actually maybe in the future we may, I don't know, find any kind of vitamin or whatever that may help us. Actually, melatonin. We did a research like some years ago trying to see if the melatonin could help in the well, in especially in young patients, and improve the egg quality, but the results were not so different. So in the end, I guess that maybe in the future we will have more information about that or not. So I think that we are trying to do our best, because it's true that there are so many patients with a poor egg quality that we should consider like testing and doing more research on that. But by the moment, there are no quite clear results on that.
All right, thank you so much. And actually, Leticia has added something here, so I want you to see what about PRP?
I don't know what's PRP. I don't know what's
Eh,
that.
rejuvenation, I believe, yes. Also, it's like the new ovarian
Yeah,
rejuvenation
it's
option.
what I was mentioning before.
Yeah.
There are some research on that, but just especially for young women. And at least by the moment, it's not something that we can use in our daily practice. So there are some data in young women that doing the kind of procedures, they can like try to have the ovaries like in a different way, and trying to, I think that's just a matter of like trying to push the ovaries not be in an so oxidative environment. But by the moment, it's not to use it in our daily practice. I'm sorry. Yeah,
Okay, thank you so much. We still need to wait for some more research.
exactly.
Yeah, thank you so much, of course. Let's go to the previous questions, okay,
Mm-hmm.
that we got. Could the hormones level predict the eggs quality for a woman who is 40? If yes, how?
Mm-hmm. As we mentioned in the presentation, there is no way to predict the equality, so we know that the best predictor is age. It's true that not all the women that are in their 40s have low egg quality, but we know that age is like the best marker and it's quite related to the egg quality. So the hormones will just predict like the egg quantity, especially the AMH, but not the egg quality. So if we want to test the egg quality, let's say like the best way is like pushing the ovaries, work for an IVF. So once we retrieve the eggs and we work with them in the laboratory, we are able to see how the egg develops in an embryo and how the embryos are doing in that way. So with that information, it's true that we may have more information about how the egg quality is, but there are no tests to know exactly the egg quality we may find. The only data that we should consider is age, but as I mentioned before, not all women have the same equality. Of course, we know that if you are older, the quality could be low, but in not all the cases is like that way, because we have many patients in the consultation that are quite young and the quality is not so good. So in the end, we know that age is important, but it's not the only factor to consider.
All right, again, thank you so much for yet another question. Okay, and here's the next one. So, can stress
Mhm.
cause low ovarian reserve?
Actually, I wouldn't say that stress may cause low iron reserve. What is known is that stress could affect the some kind of hormones secretion. I mean, if there are like the patient is like in a quite stressed moment, some kind of hormones like FSH and so on could work in a different way, because the brain is everything is related one thing to the other. So the stress itself wouldn't cause the low ovarian reserve, but it's known that, for example, in some stressful situations, really stressful situations, they may cause amenorrhea, which means that the menstruation doesn't come, and because of the alteration that the brain would have with that stressful situation in the FSH LH production. So in the end, the stress won't cause the ovarian reserve itself, but of course it could cause some alterations in some kind of hormones.
Wonderful, thank you once more for yet another question. Okay, next one is: could ibuprofen taken for pain during the period affect the egg quality?
Mhm. Exactly. So the ibuprofen and any other painkiller affects the egg quality. So if the patient needs to take some painkiller due to the menstruation, it's perfectly fine. So it won't affect the egg quality at all. So there is no, of course, apart from some other chemicals that we know that could affect the egg quality, the normal medication that we take for pain, it's perfectly fine for the quality. So the Margie may take it without any issue with that.
All right, thank you for the reassurance here as well. Okay, and let's have a look. So, how is the ratio LH FSH being used? Interesting to assess.
Actually, we normally use that ratio, especially in patients with polycystic ovarian syndrome, which is the normal situation is that FSH is slightly higher than the LH, the normal levels, sorry. But it's known that in the polycystic ovarian syndrome, there is like a disbalance between both hormones, and that ratio may change. I mean, the LH level could be quite high and the FSH not so high. So in the end, when we find a patient that has that alteration, sometimes we, and apart from other data, we may think that maybe she's having like a polycystic ovarian syndrome. Hmm.
All right, again, thank you indeed for this. Okay, and of course, more questions are coming in, so let me go to this one. It's a bit of a longer one. I did
Mhm.
2 IVF 3 months ago, but had only one egg retrieved, did not make it to become an embryo, just turned 44.
Mhm.
My AMH is 0.18. If it's too hard already with IVF help to have it naturally, will it be possible? Will be impossible. I don't need many egg, just one.
Exactly. So actually, in that patient, there are like two different issues to consider. So the first one is age, and the second one is AMH. So we know that the AMH is perfectly normal according to her age because she's 44 years old. So it's quite common to have really low AMH levels in that kind of patients. So in some cases, we think that, and actually is what happened in the consultation, that if we give stimulation, and even high doses of stimulation, the main problem is that there are no receptors where the medication could be joined. So in the end, sometimes we use like a natural cycle. So we just do like a follow-up of the follicle and that is like growing normally, and then we try to retrieve that egg. It's true that in that patient, if you are just having one egg, when we do the egg retrieval, sometimes that follicle may be empty. And apart from that, the embryo should develop to the blastocyst stage, at least to see if it's going kind of fine. And apart from that, it's really important to consider in women older than 40 years old the alterations that the embryos may have due to age. So I'm talking about the chromosomal alteration that the embryos could have due to the that age. So we know that it's not very likely to have a healthy embryo to transfer due to that 44 years old. So as she was mentioning before, it's quite unlikely that she naturally may get pregnant. And I would say that especially if we try to do an IVF, and as she tried several times, it's quite difficult. Apart from age, we're talking about the egg quality, the low ovarian reserve, and especially the way that the embryos are, or the embryo is developing, and the alterations that embryo may have due to age. So in that situation, it's a really difficult situation to deal with, because in the end, there are so many factors that are affecting in a negative way to just the stimulation and to the prognosis of that patient.
And wonderful. Again, thank you so much for yet another question and a thorough explanation once more. Okay, let's have a look. Next one is up. Could taking PMA Zolith for detox purpose affect fertility?
I'm afraid, but I don't know what's that. What
Okay,
detox?
I'm afraid I
So I
cannot help
guess,
you here.
yeah,
Not
actually,
sure.
I guess it's like a natural kind of component or whatever. Of course, it wouldn't affect, but in the end, when we are talking about some kind of issues, like it's really difficult to know if that a specific chemical will affect or not. In the end, we know that everything that could affect the environment of the ovaries in the end could affect the equality, but it's really, really difficult to know exactly if every chemical that we may take could affect in the end. We know that, for example, radiation or some kind of chemicals that are used, for example, in some kind of chemotherapy treatments, of course, they affect the quality and the quantity. But with some others and the normal and that kind of detox issues, it's really it's impossible to know if they could affect fertility or not, because it's very difficult to do any research on that specific topic to know exactly if they could affect or not.
All right, of course. Thank you so much indeed for this. Okay, yes, Margie has added it's a mineral from volcano. So just so
Mm-hmm.
we know as well. Thank you so much for uh,
Oh, thank you.
yeah,
Oh,
something new for me as well.
for me also. So, well, it's nice to know something new. Well,
Exactly.
actually, I can't give you an answer because like I don't know if it could affect or not. As I was mentioned before, being natural doesn't mean that it couldn't affect the equality or whatever. So being natural is just we know the origin of that chemical, but in the end, it's like impossible to know if it could affect or not. So I know that there are so many different issues that are trying to improve the equality or at least trying. But I couldn't give an answer on that because I think that maybe it's quite a new thing. But actually, I didn't know about it before. So I can't give you an answer. I'm sorry.
Of course, that's totally understandable. Thank you so much indeed, though, for the question. This is something that we now we will know a little bit more on that as well. Thank you so
Exactly.
much. All right, and let's have a look at the next question. So, is there a perfect level of hormones for women starting an IVF, Onyx, age 35, AMH 0.6, normal BMI? It's a first IVF cycle.
Mhm. So actually, when we start an IVF cycle, we normally test both estradiol, sometimes LH, and progesterone values, right? So when we are starting an AM and stimulation, we try to have like the hormonal levels quite low, which means that the ovaries are like resting. So when we find, for example, estradiol a bit high, it could mean that maybe there are some small or even big follicles that are producing hormones, and that hormones may affect the stimulation development. So that's the reason why we always check the hormones before starting. Sometimes, actually, in the past, we tested also the FSH, but we decided not to do it anymore because the results wouldn't change the protocol we were using. So in that patient that is quite young, and the AMH level is not very high. Actually, it's quite low. So I guess that maybe her doctors will start the stimulation with a high dose of stimulation, trying to retrieve as many eggs as possible. Okay, she's quite young, which is a good news to consider. And actually, if she has also a normal body mass index, well, it will help for sure also. But actually, I would say that the hormonal will normally consider the estradiol level below 70 picograms per milliliter to say that it's perfectly normal to start the stimulation.
And amazing again. Thank you so much for that interesting question, of course, for your help. And there are like three questions left. We will be slowly finishing, but of course, if you haven't asked your question, just go ahead and type it in, okay? And let's see. The question is here: what is the purpose of taking FSH and LH for daily stimulation if the LH is for ovulation?
Exactly. So the idea is that, of course, LH is also involved in the follicular growth. So normally when we are stimulating the ovaries, we start normally with FSH or a kind of FSH to stimulate the follicular growth, and then sometimes we add some kind of LH, especially in older patients that may have that should be well they should use that LH action also, trying to make the follicular growth in a better way. I mean, so the idea is that with that hormones, we are trying to push the ovaries produce more more follicle. So we normally produce just one follicle in a natural cycle, and the idea is trying to push the ovaries producing more follicles. So if we use that hormonal action, what we are going is that making that FSH or LH go to the receptors in the external part of the follicles and making those follicles grow. In the end, if we make, for example, 5 follicles grow properly, we know that we are going to retrieve around 5 eggs, which is not the normal and the natural situation that we may find in a natural cycle. So the idea is to retrieve a higher number of eggs.
All right, thank you. Okay, and let's have a look. Letitia has added one more question. How do we know if the quality is good or not? If it goes to blastocyst day 5 with good rating, means good quality?
Actually, when the blastocyst is on day 5, there is it's not just the egg. Of course, the sperm has a lot of to say also, but we know that the first days of the embryos develop are related to the egg quality. I mean, if the embryo is doing quite well between the day after the fertilization and day 3, normally if the egg is a good quality egg, the embryo will develop properly. After the 3rd day, we know that it's the moment when the sperm starts to act, and if the embryo sometimes does not develop as the embryo should, sometimes it could be to a male factor also. So we normally consider that if the embryo is doing fine during the first days of development, it's because the egg has a good quality. Of course, it's not just as easy as saying that way, but it's like a slight idea of what we normally consider in the laboratory. So in the end, of course, the egg should have some kind of characteristics and that are normally seen in the laboratory, just to know that the quality is at least normal. And afterwards, after doing the fecundation of the eggs, normally we see how the embryo develops in the first days. And normally, as I was mentioning before, if we have a good quality embryo, normally it's because the egg at the beginning had a good quality also.
All right. Again, thank you so much for answering yet another question. And as you can see, again, some questions are coming in. Let me go to this one, okay? So could a bad-looking embryo, when PGS tested, actually be a good embryo?
It's I wouldn't say a good or a bad embryo. So there are two different things in that question. So first of all is the quality of the embryo, and secondly the the PGS testing. So we may have a really good quality embryo, and once we test it with a PGS, sometimes the outcome is it's not a healthy embryo. So the quality is not related to the result of the PGS. So I mean, there are so many embryos with really good quality, high good quality, and in the end their test is not healthy embryo, which means that they don't have the correct chromosomes. So the quality of the embryos is not related to the way the PGS the result of the PGS, I mean. So there are so many research trying to guess if the quality was related to the PGS result, but by the moment there are no relation between the quality and how the PGS result will be. So if the embryo, for example, is not like the top quality one, but it's a healthy embryo, the implantation rate of that embryo would be quite high. The opposite happens. So if the embryo has really good quality, but it's not a healthy embryo, and we test it, for sure the embryo wouldn't implant, or in case it implants, it could end in a miscarriage. So in the end, the PGS just tells us if the embryo is healthy, and in case it is, the implantation rate would be increased, but the quality is not related to the PGS results.
All right. Again, thank you so much. Yet, once again, of course, I'm just looking. Of course, there are more questions here. Could creating embryos in a cycle tell about good quality, or it doesn't matter? Egg quality, of course.
So it's true that, as I was mentioning before, that if we create an embryo in the laboratory, we can have like quite a wide idea of how the eggs are also. So if we have a good quality embryos, because both eggs and sperm are fine. So as I was mentioning before, the quality of the embryos is not related to the PGS results in case we perform that. And actually, it's known that the best way to know how the ovaries are working is like trying to put that ovaries in under an stimulation to know exactly what we may expect from them. I mean, if we have the eggs in the laboratory, we create the embryos, it's quite likely that we are going to have quite a wide information about the eggs and the embryos themselves. So in the end, if we have those embryos in the laboratory, we have been checking them since they were eggs and sperm until we decide to freeze them or to transfer them. So in the end, the idea of the cycle, of course, is creating the embryos for transferring them, not creating the embryos just for creating them, because the idea is transferring them at any point and making that patient get pregnant. So in the end, the information we will get is really important, but it will be information in the laboratory. So it's not so easy to have, or at least to try to guess what we could expect from the ovaries, unless we do a stimulation and we retrieve the eggs with the idea of making that patient get pregnant.
All right. Okay. Thank you so much. Yes. Sorry. Once again, of course. And actually, now we have another question. Okay. So if
Mm-hmm.
I take COVID vaccine, how long to wait until I schedule like retrieval?
Well, actually, there are no data if the COVID vaccine could affect the quality or quantity at all. But it's true that if the patient wants to get pregnant, it's recommended to wait between 1 to 2 months to get pregnant, which is different from like a retrieval. In case, for example, the patient wants to freeze her eggs. So if she just want to freeze her eggs, if there is no information about waiting or not. So I would say that she wouldn't need to wait for the egg retrieval. So she can use the vaccine at the same time as a stimulation. But in case she wants to get pregnant, I would recommend or suggest waiting to do the vaccination, and afterwards waiting between 1 to 2 months to get pregnant.
All right. Again, thank you so much for the explanation. This is definitely a question you also receive quite often nowadays, possibly. Okay.
Mhm.
Now, one more question is right here. So maybe, possibly, that is our last
Mhm.
question. Could
Mhm.
the O2 level during stimulation tell about the result? Higher level, better
Mhm.
result, better quality?
Actually, what's known that the estradiol level is related to the number of eggs retrieved. I mean, so when we have a patient with a high estradiol level, it's normally because the response was quite high also, but it's not always that way. Depending on the stimulation we do, Sometimes we may find not so high estradiol levels, and then we retrieve a really high number of eggs. So in the end, estradiol is related to the number of eggs that we may retrieve, but it's not the only data we should consider, which is not related with the quality's estradiol level. So as I mentioned before, the estradiol is not related, it's not a good marker of ovarian reserve. And during IVF, the only information that the estradiol may give us is the approximately number of eggs that we may retrieve. I mean, if the estradiol level is quite high, it's because the ovarian response is also high, but it's not related to the egg quality anyway.
All right, and Margie has added one more question. Okay, so is it safe to stimulate with FSH higher than 300 units?
Actually, I wouldn't say that it's not safe. Of course, it is safe, but the issue that we should consider is that it's useful or not. So when we have a patient with a really low ovarian reserve, we could her, I don't know, 600 units if we want, because the issue is that there are no receptors in the ovaries to make that medication work properly. So in the end, we know that giving a stimulation of more than 300 units doesn't make any sense because the effects won't be so good. The main problem is because the ovaries are not having a good number of follicles and are not having either any a good number of receptors in where those medications could act. So in the end, of course, if we give that high dose of stimulation, the idea is trying to make the ovaries work as much as possible, but using more than 300 units nowadays is not very commonly used because we know that the results won't change at all.
All right, again, thank you indeed for that. Okay, there is a thank you, but of course, I guess we will be finishing. Okay, there are some thank yous coming up, but also remember that if you have any other questions or you might have them later on, remember that you can get in touch with Dr. Esther and her team, and I'm sure that they will be able to help you out as well. And of course, I just want to also thank you everyone for joining us tonight. And of course, Dr. Esther, it's always great to have you here. And as you can see, there are some thank yous
Thank you.
for you here as well.
Thank you.
And there's one more.
Very welcome.
Thank you so much. And of course, before I let you go, anything else you would like to add?
No, actually, well, I hope that that presentation was like clear enough because sometimes the hormones are not very easy to understand. So I hope that all the patients and everyone that has joined today has the opportunity of learning a little bit about the hormones and why and when we use them.
Exactly. Thank you so much indeed for explaining it. I definitely think it was very well received as well. So thanks so much. And once again, of course, I just want to mention, as you know, it has been recorded. It will be available on our website tomorrow, myivfenses.com. And if you go to our YouTube channel, but also to our website, you know that there are 300 IVF webinars. So you can just go ahead and check it out. I'm sure there are many interesting information there for you as well. And yeah, thank you so much, Dr. Esther. It's been great to have you here. 300 webinars, and I'm very glad that you are also part of it. And you will be redirected to Dr. Esther's profile, and you will find that she has been with us before. There are 2 other webinars with her, I believe. So thank you so much indeed. And of course, as you know, 300, this is like I would say just maybe not the beginning, but of course we are definitely planning more and more webinars. So I hope you will be able to join us. We are back on Monday at 8 p.m. So if you haven't registered yet, go ahead and do it. All right. Thank you so much and have a lovely evening, Dr. Esther. Thank you until our next webinar. Okay? Perfect. Thank you. Bye.
Bye-bye.